So as you all know, a healthy ocular surface, to have a healthy ocular surface, you need a healthy limbus. And the reason for this is that the corneal epithelium is maintained in a healthy state by the epithelial stem cells which are located in the palisades at the limbus. And the palisades continuously supply epithelial cells which go over the cornea, replenish it, because you're constantly losing epithelial cells from the corneal surface like any other surface epithelium because of desiccation, because of exposure to the environment. And the limbal stem cells which are located deep down in the limbal palisades to make sure that this continuous supply is maintained and the corneal epithelium remains smooth and uniform, and so that you have good vision. But any damage to the limbus results in a clinical condition which is called limbal stem cell deficiency, and cystic epithelium on the surface, superficial vascularization, the surface is not healthy, keeps breaking down, and there's a loss of vision. Now, depending on the extent of involvement, it can be unilateral or bilateral, it can be total or partial. Total is when the entire limbus is affected. Partial or subtotal is when some parts of the limbus is affected and some parts is spared. Now, limbal stem cell deficiency, again, another important aspect to it is whether the surface is wet or dry. So typically in ocular burns, you would see a surface which has some luster, which has a little bit of tearing. Sometimes it's good tearing, or you can have a dry surface like in Stevens-Johnson syndrome or toxic epidermal necrolysis sequelae, where you have a completely dry surface, and you can find that the corneal epithelium almost looks like skin, which is known as dermalization. So instead of conjunctivalization, but at least you have some wet epithelium on the cornea, you have dry skin-like epithelium. Now, the treatment algorithm that we follow for ocular surface disease due to limbal stem cell deficiency goes somewhat like this. So if you have a patient with a unilateral corneal blindness due to limbal stem cell deficiency, then we look for whether the patient has visual potential or not. And if the patient has visual potential, we look at other factors. Like I just told you, you have to look, one of the important prognostic markers is whether the surface is dry or wet. And you also have to look at the lid, so if the lid function is good or not. So if there are any lid problems, trichiasis, entropion, lid notching, exposure, those need to be addressed first. So if the surface is dry, or if the patient does not have any visual potential and it's a unilateral problem, we usually don't do anything for those patients. However, if the surface is wet, then we can try a limbal stem cell transplantation. Usually in these cases, it's autologous, so you can take the limbus from the unaffected eye. And if the surface is dry or the patients don't have visual potential, as I just told, we don't usually do any surgical procedures for them. So we give them some kind of a cosmetic correction. However, if the patient has bilateral problem or it's the only eye of the patient, you don't have autologous source of the limbal tissue. And usually for these patients, we do a keratoprosthesis. Again, if there is visual potential and it's bilateral and dry, you have other keratoprosthesis that you can try for these patients. And if there is no visual potential, of course, these are not eyes that you should play with because the risk of complication is very high. So in limbal stem cell transplantation, fortunately, although limbal stem cell deficiency is a very rare but severe form of corneal blindness, it can be addressed. You can take healthy limbus from a donor eye, if possible from the healthy fellow eye, because then it's autologous, doesn't have the risk of immunological rejection, you don't have to immunosuppress the patient, and you can transplant it after removing the pathological pannus from the affected eye. And the conventional technique, as originally described by Kenin and Sayan, is where you take a large lenticule which contains peripheral cornea, limbus, and conjunctiva, and you can take 3 clock hours or more and transplant it on the ocular surface. Or you can take a small bit of limbus and grow it in the lab and expand the cells on a suitable substrate, which can be fibrin or can be an amniotic membrane, and then transplant it back on the cells. You transplant a sheet of cells instead of just the limbus, and this works just as well. So both these procedures are known to be very effective in treating ocular surface disease due to limbal stem cell deficiency. Now the nomenclature is a little confusing. It depends on where you take the donor. So whether the donor is living or cadaveric. So you can have, if the other eye is healthy, then usually you take it from the other eye where it is autologous. So this technique is called congenital limbal autografting. If you take it from a living donor, then it's an allogenic transplant. This can be living related or unrelated. So it can be somebody who's related to the patient or somebody who's unrelated. It can be HLA matched, it can be HLA unmatched. Depends on whether you do HLA matching. Usually very rarely, because matching is very expensive, is that done. So mostly it's living related, may or may not be HLA matched. And if you take it from a corneoscleral rim where it's cadaveric, then it's called a keratolimbal allograft, it's KLA. So usually we take 2 clock hours, which are around 3, we take 2 lenticules, which are around 3 clock hours in length, and that is transplanted on the surface, on the recipient eye. So these are 2 different techniques of doing the same procedure. One in which we started the dissection from the conjunctival side, and the other where we started the dissection from the corneal side. It's usually seen that if you do the dissection from the conjunctival side, the chances of having problems in the recipient eye are less. So essentially that you take the whole large lenticule and you put it on the eye, and you can either suture it or stick it with glue. Usually people prefer suture glue. Conventional LSCT has been around for many decades now, and it's known to be pretty efficacious in treating ocular surface disease due to LSCT. But because you put the lenticules in the periphery, it takes time for the cornea to epithelize, because the cells growing from the limbus inside. And sometimes there might be problems. You might end up with persistent visual defects, etc. The major problem with the conventional technique is that not everybody is as skilled as, for example, Dr. Rao, who described his technique in this study in 1999. And you can end up causing damage to the donor eye because you're taking so much of tissue from there. And if you don't have too much experience in dealing with ocular surface diseases, then you can end up damaging the donor eye, like in this series. You can see this is the transplanted eye, which has had recurrence subsequently, which can happen. But you can see that in the donor eye also, because probably of deeper dissection or not doing a particularly good technique, they've resulted in some amount of donor site conjunctivalization also. And this is very frequently reported, especially in people who are starting out doing this procedure. So you can work around this by doing a cultivated transplant where you take only a small amount, only 1 clock hour, so there's hardly any chance that you're going to damage the limbus because you're taking so little tissue. There again, the nomenclature depends on where you take the donor tissue from. The Cornea Society says that we should call this procedure by these very complicated names, but we usually call it cultivated limbal epithelial transplantation or CLET. So here you take a biopsy, and that biopsy goes to the lab, then the cells are grown on an amniotic membrane, and then we transplant the amniotic membrane on the surface. So the amniotic membrane basically contains a ready-made layer of epithelial cells. At NUPI, we used a xeno-free and feeder-free culture technique, which used autologous serum for culturing the cells, and this was relatively inexpensive as compared to using feeder cells and xenobiotics, which is routinely done in other centers. The benefits of cultivating the cells outside is obvious. It's very safe for the donor eye, and then you have a ready-made sheet of epithelium, so healing is faster and visual restoration is faster. And we published our results of this is about 10 years of experience of doing cultivated technique of transplantation. And as you can see, the outcomes are sometimes very satisfying. And we know that it's safe for the donor eye, it doesn't really cause any trouble. If you see how the donor side heals, you'll find that it actually heals from the corneal side to the conjunctival side. The defect in the cornea is the last one. We also found, interestingly, that that if your first transplant fails, which can happen in about 25 to 30% of patients, and if you go back and take another biopsy, cultivate the cells again and put them back onto the eye, you can treat 2/3 of cases of failure. So if you combine the efficacy of the first and the second procedure together, you can actually address about 90% of the patients with unilateral LSCT with wet surfaces. If you need to replace the cornea as well, it's probably better if you wait, do the limbal transplantation first and then do the keratoplasty, rather than doing them together, where the success rate is much lower. We also found, interestingly, that if you have a patient with unilateral limbal stem cell deficiency and which is partial, so you have 3 or 4 quadrants of the limbus is involved, you can take the donor limbal biopsy either from the same eye or from the opposite eye. It really doesn't matter. And then you can grow them and put them back. So whether you take the biopsy from the same eye or the opposite, well, with the Italian group, which is the other big group which does this procedure, we have found that it doesn't work as well in children as it does in adults. The success rates are much lower. Unfortunately, a lot of our patients are children, And there are other problems with the cultivated technique in the sense that it's costlier. Not everybody can have a stem cell lab, and it's essentially very institution based. So only a few institutions have this procedure available for the patient. So recently we have described this new technique where we do in vivo cultivation. So we don't take the biopsy and take it to a lab and grow it. It's grown in vivo, so you put the amniotic membrane just as you would do, but this amniotic membrane does not contain any cells. So you remove the panels and put the amniotic membrane in glue, and then you take the limbal biopsy that you've taken from the other eye, and you just cut it up into small pieces. This procedure is called simple limbal epithelial transplantation. Simple just to indicate because the procedure is much simpler compared to the previous techniques where you either had complicated stem cell labs or you had to take a larger biopsy, which in itself was a complicated technique. And you just spread these pieces around, put 1 drop of glue on top of them, and that's pretty much the end of the procedure. And you put a bandage contact lens. We wait for the glue to gel, and you put a bandage contact lens on top. So initially we had published our results in 2012. So these are pre-op photographs, and this is a time course showing how these eyes heal. And you can find at the end of 1 year, most of them will have a clear cornea and the surface will have epithelialized. One criticism of an initial publication was that it only dealt with patients who had good prognosis and not with complicated situations where patients had previous surgeries or had leg problems, etc. So we've recently analyzed our results, and these are long-term results of 64 patients who had 1 year of follow-up. And you can see that unlike in the cultivated technique, the long-term outcomes in children and in adults is pretty similar in the simple limbal epithelial transplantation as well. We also found that in children who are less than 8 years of age, the visual recovery takes more time because they also need treatment for amblyopia. But over a period of time, the visual recovery is pretty comparable. So just to give you a few illustrative cases, each panel is a different, both eyes of different patients. So on top you have a child with a persistent epithelial defect, having undergone 2 amniotic membrane transplantations in the past. This is after SLED, stable surface. You can see it's not vascularized. There's a bit of scarring because of the PVD. The patient is 28T. In the middle panel, there's this young boy with very severe ocular surface damage, severe symblepharon coming onto the cornea. This is the same patient after 1 year wearing a RGB lens. It's 20/60 corrected with RGB lens. And in the bottom panel, you have this very angry looking ocular surface, severe alkali burn, having undergone amniotic membrane once. And you can see this not really worked. And this is the same patient after SLED. You can see a little bit of peripheral vascularization. But here the cornea is clear, the patient is seeing and is maintaining the surface. Again, a few more complicated cases. The top panel previously failed cultivated limbal epithelial transplantation. Same patient after SLED, stable surface, clear cornea, a little bit amblyopic. Patient is 20/60 uncorrected. In the middle panel, you had this patient who initially presented to me. The father of the child wanted the eye enucleated because it was so ungainly, and the child could not close the eye. It's symptomatic, stopped going to school because of this appearance of the eye. And we did a SLED for him, and this is the appearance of the eye after, and he's still 2 years out. He's still doing well. Again, in the bottom panel, patient with firecracker injury, failed cultivated transplant, same patient after SLED. So these are like exceptional outcomes. You can, if you saw the patient, you wouldn't make out which eye had the injury or which eye had surgery. So SLED definitely has an advantage over the 2 previously described techniques. A, that you don't need an expensive stem cell lab, you have no risk of causing any damage to the donor eye, and that your success rates in children and adults are the same. So I think it's a definite improvement over the existing techniques. Is it easily replicable? We recently had this workshop and a meeting where people who are now doing SLED, not just in our institute, but also in other places in India and outside India and other parts of the world, we had a meeting where people shared their experiences. How easy was it for them to do SLED? What were their outcomes? And it was really very encouraging. And we intend to have these meetings year after year so that and help people who want to start off with this procedure. So if any of you wanted to start doing SLED, you can just send us an email, and we will send you all the material that you would need to start off. So I think chronic ocular surface disease due to LSCD is definitely treatable, and now we have more simpler techniques to address these problems. You just have to remember the cell-based therapy does not work in eyes that have lid problems, does not work in eyes that are dry. So that is one thing that you have to watch out for. And I think with the advancement in the technique of surgery, the simplification of the surgical technique, it has a potential for wider application. So that people who do not have sophisticated setups can even do this procedure for patients and treat their patients who have chronic ocular surface disease. limbal stem cell deficiency. Thank you.